Good afternoon, everyone, and welcome to today's webinar. My name is Eric Chetwin. I'm with Everbridge, and we're excited today to be able to present this webinar with Dr. David Levine. Just before we get started, we want to go through a couple of housekeeping items with you. Dr. Levine, if you could just advance to the next slide. Some of the basics of the housekeeping for you is that we will be doing a recording of today's webinar presentation, and you will receive an email following the presentation with a link to that recording, as well as a copy of the slides and links to additional resources. Next slide, please. If you wish to ask a question during the presentation, you can ask a question anytime during Dr. Levine's presentation. Just simply go to the control panel and type your question into the question window. We will cover those questions at the end of the session, and Dr. Levine will try and answer as many of those as possible as we go through the conversation. And next slide. And with that, I'd like to take a moment just to introduce Dr. David Levine from Brigham and Women's Hospital. As you can see, Dr. Levine is a practicing general internist and investigator at Brigham and Women's, and also at the Harvard Medical School. His research focuses on digital health, care redesign, and the quality of delivered healthcare. And I think he has a very exciting presentation for us today. So with that, I will hand it over to Dr. Levine.
Great, thank you, Eric. And thanks everyone for joining us. Really excited to speak with you about our work in hospital level care at home for acutely ill adults. And so as Eric mentioned, I am a general internist. I do primary care in a community health center in Boston, and then also do hospital work and a lot of advanced home-based work at Brigham and the surrounding area. Always want to start off with this quote from Walter Cronkite, who said that America's healthcare system is neither healthy, caring, nor a system. And that makes me, frankly, a little sad to be part of that system because we work so hard in it all the time. But at the same time, it also pushes you to really change that paradigm and make our system one that is healthy, caring, and a system. And so what I want you to think about for a moment is what you think you see in this top left corner here. Looks like an older picture. There's a bed with somebody in it, with windows, and a lamp, and a water jug. And if I were to ask you what you thought this was, probably get a lot of answers all over the place. But this happens to be a hospital in the United States in 1933. If we look at the top right now, we again have a hospital, very similar surroundings, bed, patient, window, water jug, things of that sort. If I were to ask you what year it was, the answer here is it's about 1945 now. And then in the bottom left, looking at what we see here, again, very similar set of items, and it's now about 1960. And then finally, in the bottom right, is a present-day hospital bed. And the reason I show these four images is really because we have not changed almost anything in terms of the structure of how we take care of acutely ill patients. Absolutely, the medicine has changed, the diagnostics and imaging have changed somewhat, but really the way that we care for patients and where we care for patients has changed very little in almost the last century. We still put patients in a bed, we still round on them in the morning with a team. We occasionally, if patients are lucky, come back to them in the afternoon. We still have a physician and nurse hierarchy. And so a lot hasn't really changed. And this is getting toward hoping to turn America's healthcare system into a healthy, caring system. And I think what we need to do in order to realize some of those goals is to take digital health technology, which is rapidly changing a lot of how we practice medicine, and then take really agile and sometimes experimental teams and oftentimes put those teams in the home and put those two things together to really realize some of these systemic changes. And my argument is that if you take just the digital health tools and try to solve a problem, it's often going to lead you in a tough spot where you're not as successful as you want to be. And if you take just the people and you throw people at a problem, you also may not realize the goals. But I think if you marry those two together, it really offers an opportunity to see some pretty impactful changes. So in the next 35 minutes or so, I wanted to go through with you some background about home hospital, our aims that we approach the problem with, how we do home hospital, what our teams look like, how we communicate, what's necessary to get buy-in for home hospital, and then wrap up and hopefully answer a bunch of your questions. I do want to also just point out, it's very important to me personally that I have no disclosures or conflicts of interest in this work, and I'm not being paid to give this webinar or anything of that sort. So by the time we're done, I would hope by the time you click end webinar, hope that you could be able to identify patients who would benefit from a home hospital program. Would hope that you would be able to build a team of clinicians and caregivers who can execute a home hospital program, recognize how to get buy-in from hospital administrators for a home hospital program, and then formulate effective communications for a home hospital program as well. I think we'll get to some of these in not as much detail as I know we'd all like in just the short time we have. So what is a home hospital? Really the best definition we have is that it's a community-based provision of services usually associated with acute inpatient care. And there's really three models for how we do that. One is an early transfer to home model. So this is where a patient is hospitalized in a traditional hospital. They've probably been in that hospital for about a day, and they have a stable acute care plan. They still need acute care, so they still need antibiotics by IV, or they still need diuresis by IV. But that acute care plan can actually be carried out in their home with an advanced team. And so they leave the hospital and end up in the home with a home hospital team. That's the early transfer to home model. Then there's the substitutive with the emergency department model, or ED. And this is where a patient travels from home to the ED, gets their first round of triage, diagnosis, and treatment. And then the decision is made that they need acute care, but they actually return home for that acute care. And then there's substitutive without the ED, where a patient signals the alarm, there's an acute care need, and the home hospital team actually pushes directly into the patient's home, and they never touch the ivory tower, they never touch the ED at all. Mostly I'm going to focus on the care model in the middle, highlighted in yellow, and that's because that's what we have the most experience with, but we're certainly broadening ourselves and hoping to move into other models quickly. So I don't know how many clinicians we have on the line, but certainly for the clinicians on the line, and I'm sure most of the people on the line, no need to really tell you that there are problems with hospitalization. But I'll just quickly mention that there's several unintended clinical consequences. So about 20% of our older adults will become delirious during an acute hospitalization. About 1 in 3 of our older adults will actually lose functional status that they never regain. And about 1 in 10 of all comers in the US will have some sort of a hospital-acquired condition, whether that's an infection, a fall, a medical error, or something that's unintended that happens to them while they're hospitalized. There's actually also pretty poor inpatient access, which is fairly regionally and contextually important to think about. I'm in Boston, and while it seems like we have a hospital on every corner in this town, most of those hospitals are actually over 100% capacity on their medical wards. And from the time that you step into an ED to the time that you get your disposition somewhere else, it's often a 12-hour wait. And then finally, as many know, it is incredibly expensive to take care of hospitalized patients. It eats up about 1/3 of our nation's healthcare dollars. Almost $1 trillion is spent on inpatient care. And we often do that at a negative margin for run-of-the-mill internal medicine admissions. So really, because of lots of these problems, there's certainly a need for home hospital. And this is all about getting the right care to the right patient at the right time in the right place. And so we have, all the way on the left here, the highest acuity care that we can provide is in an intensive care unit. And then all the way down this continuum is things like telehealth, home health, to slowly monitor people where they are. And so what we're trying to do with home hospital, and I use the word cherry picking, and you should too, we are trying to cherry pick patients who would normally need the medical floor, nothing more and nothing less. And we're then hoping to provide that care in the home. And so we're really trying to prognosticate the need not for the ICU, but the need for acute care on a general medical floor. And really trying to change the paradigm from I feel unwell, I need to go to the emergency room till I get admitted, to instead I become admitted, but I'm admitted at home. And I'm happy to talk more if people are interested about how I think this is really essential to thrive in a globally budgeted environment, particularly when we have shared risk or bundled payments, and can be, depending on your context, a cost-saving mechanism in our current fee-for-service system as well. So our work is certainly not the first time that home hospital has been done, quite the contrary. Home hospital programs robustly exist globally in Victoria, Australia, Torino, Italy, the entire country of France, all have very robust home hospital programs. America, frankly, is pretty far behind when it comes to this. And the two largest American studies are on the screen right now, both done by Bruce Leff and Cryer and colleagues, and were non-randomized, quasi-experimentally designed studies that essentially showed equal safety, equal quality, a 20 to 30% cost reduction, and improved patient experience when patients were home hospitalized. Again, these are fantastic studies of this sort of an intervention. I think some of the criticisms here come in that they were not randomized controlled trials. And then the question sometimes comes up of whether or not patients who were home hospitalized in these studies, because they weren't randomized, would have actually been hospitalized originally. Or are these just really the soft admissions who you could have sent home, but you didn't? And so it's certainly a fair criticism, but these studies are excellent examples of home hospital work on a small scale that's happened already in the US. So for our work, we really wanted to compare to usual care in the hospital for adults who would normally have been admitted. And we primarily wanted to demonstrate a 20% cost reduction. And we secondarily wanted to maintain safety and quality of care. And then we also wanted to improve the quality of life and patient experience that was delivered to patients. So this is how it worked. A patient would present to the emergency department, and the decision would be made to either admit them or discharge them. Obviously, if a patient was discharged, we wanted nothing to do with them. We wanted them to go home as the ED wanted them to. And really important here is that our team, our research team, did not alter the decision-making and processes of the ED team. And I think that's a very important point because there are certainly ways to influence who might be directed into a program like this if you are upfront trying to direct people toward this sort of an option. In any case, if the decision was made to admit to internal medicine or cardiology, and a patient met our home hospital criteria, which I'll talk about in a moment, and the patient agreed to enroll, then we would enter that patient into our study. If the patient did not agree to enroll, or if the patient didn't meet our criteria, we would just admit them to the hospital as per usual care. But if they did, then we would randomize them. Again, importantly, we were randomizing people after they agreed and after they met our criteria. So this actually bummed out about 50% of the patients because half of them who wanted to do the study were told, sorry, you ended up in the control arm, and they were admitted to the hospital just like normal. The other half did get to enter into the intervention arm and went home, and our home hospital team would then deploy in their home, which I'll explain in a moment as well. So which sorts of patients did we treat? We started with things like any infectious process, including cellulitis, complicated UTI, pneumonia. We would treat patients with heart failure exacerbations, as well as patients with COPD and asthma exacerbations. So in order to be included in the study, you had to reside within our catchment area, and you had to be an adult, and you had to have one of those primary diagnoses that I just mentioned that was determined by the emergency room team. And we were not able to accept patients if they were undomiciled. So again, it's home hospital, you need to have a home. If you resided in a skilled nursing facility, or if there was domestic violence going on in the home. And then we ruled out several sorts of clinical criteria as well. For example, if patients had end-stage renal disease or they were at high risk for clinical deterioration. So our team was very sleek, and that's how we designed it. This was really a wonderful experience to be able to design from the ground up, right? Get the right care to the right patient at the right time and the right place, as opposed to, this is what a hospital has, how should we pare it down? And so we started with, and again, this may not be the right answer, but the way that we started was with a nurse and a doctor. And we were then able to ratchet up or down a home health team to complement that nurse and doctor as necessary, and could bring in physical therapists, occupational therapists, social workers, and others. And so when we were in the home, we were able to do lots of interesting diagnostic work. We were able to do point-of-care blood tests, able to do ultrasounds and echocardiograms, as well as portable chest x-rays for our diagnostic work. And then for the pharmacy aspects, we were able to bring all the acute inpatient medicines to patients' homes with our Brigham pharmacy. Our pharmacists were such an incredible partner in this work, being able to provide us with all the IV medications that we needed to help treat patients. And then we would keep using the patient's chronic outpatient meds, and this is mostly for patient engagement, to keep them motivated in their care, part of the plan, such that we helped them continue to manage their chronic outpatient medicines as indicated, of course. And then we had a tackle box of urgent medications. Essentially, this was a code cart light with all of our workhorse antibiotics, our workhorse diuretics, and a slew of other medications, should we need to increase or decrease a certain kind of therapy. We also used ambulatory infusion pumps. These are not the pole-mounted pumps that tether patients to their hospital beds and get them all tied up. This is a simple pump that's worn on your waist or around your shoulder, and is already patient-oriented. We used all peripheral IVs when indicated. There's this fun myth in America that peripheral IVs stop working as soon as you walk outside of a hospital, and it's really not true. They work quite well at home. And then if a patient had an oxygen requirement, for example, we could bring them oxygen as well. So communication was really, really important, as you can imagine, because our team was dispersed often around the Boston area, and needed to be in very tight-knit communication, both among clinicians as well as ground support, and between patient and clinician. And so here we used an encrypted SMS platform that allowed us to first and foremost contact patient and clinician and put those two people in contact with one another, as well as be able to discuss things among clinicians with secure text messaging. And then we used a cloud-based task system that allowed us to task each other with things, and allowed us to, in a very nice way, streamline a lot of our workflows. And then finally, encrypted video also was an important part of what we did in order to contact a patient. Or, for example, if a nurse wanted to show a doctor something and the doctor wasn't on site, that could be done. Or a patient could fire up a video and show a nurse, this is what my IV looks like right now, is it okay? Things like that. And then, of course, we used the telephone a lot. It's one of the older communication devices we have, synchronous communication devices we have, and it's fantastic. And honestly, often outstripped some of the more technologically savvy communication devices that we now have, just because it's so pragmatic. So for monitoring, we did not use this. This is what many of our amazing tele-nurses spend all night keeping on patients in the hospital as they rip them off. Instead, we used this. It was a small patch that goes on the patient's chest. And it was really a nice device that allowed us to get a continuous sense of how a patient was doing. So we were able to stream continuous temperature, heart rate, and respiratory rate, continuous telemetry. We're able to continuously observe patients' activity, whether that be posture, steps, God forbid, falls, and things of that sort. And this also was very helpful in terms of allowing us to downsize certain staff areas that would normally in the hospital need to be on 24/7. So we just recently, about a month now ago, published the findings from our pilot, which was performed actually late in 2016, giving you an idea of how long it takes to publish things in a peer-reviewed journal. Embarrassing. But this is a tiny pilot that we did, 20 patients. 9 went home, 11 stayed in the hospital. We've since then repeated this in a much, much larger way. But this is what I'm able to share with you now because it was just recently published. And so essentially you can see here patients in both arms spent about 3 days admitted in either the home or admitted in the traditional hospital. And what I do want to draw your attention to is the large, but sometimes in this study not statistically significant, but the large decrease in utilization during the acute episode. So, for example, 11% of the home-based patients received imaging during their admission, whereas 45% of the control arm patients did. Similarly, 6 lab orders were ordered for the home patients, whereas 19 lab orders on average were ordered for the control arm. The control arm, about half of those patients received some sort of a consultation while they were in-house, whereas none of the patients at home did. And the disposition to home health was also about halved. And again, this gets to the idea that when you're in someone's home, you have a really good understanding of what they need when you're going to leave them. That's very hard to ascertain when you're in the hospital, and oftentimes we order home health as a crutch because we're not sure what the patient needs. But it is actually a very expensive piece of the puzzle, and we were able to cut down on our referral to home health in the home-based arm. And then we do see here a decrease, but a non-statistically significant decrease in 30-day readmissions. Only one of the patients, or 11% of the patients in the home group, was readmitted in 30 days, whereas 4, or about 36% of the control arm patients were readmitted in 30 days. In terms of safety, again, this study was absolutely not powered for safety outcomes. You would need tens of thousands of patients to power around some of these safety outcomes. But suffice it to say that in these 9 patients that went home, we did not see any sort of safety events. And one of the most common safety events is transfer back to hospital that we think about in the home hospital world, and we did not see that happen for our patients. Again, corroborating the previous quasi-experimental, non-randomized trials that have been done. And you can see in the control arm, a few safety events, nothing really alarming either. And I'm not showing here, but essentially all of those standard hospital quality measures, things like getting your EF evaluated if it's less than 40%, in a heart failure exacerbation, all of those measures were met equally in both groups. Here, though, we do see some interesting quality and activity scores that I want to bring your attention to. So for quality of care, we saw no difference in pain scores, no difference in inappropriate medication use, fully use, restraint use. What's striking, though, is that what we were able to measure was activity. And this is almost never a recent study in an Israeli hospital was recently out showing activity in hospitals, but very little has actually been done to quantify this. And so we were able to show that the patients in the control arm were sleeping about 1 hour less, almost an hour and a half less than the patients in the home arm. Again, this was not statistically significant in this tiny study. And they were walking much, much less in the traditional hospital. And they were able to essentially walk almost 1,800 steps in the home arm and only about 160 steps in the control arm. And for the clinicians on the call or family members in hospitals, this doesn't surprise anyone, because what do patients do when they're in a hospital? They sit in bed. And so really showing a striking difference when we're able to change the site of care for a patient. And we think that that has then a lot of repercussions in terms of how well people are able to heal and how they don't lose that functional status that we talk about 1 in 3 older adults losing when they're hospitalized. Also looked at patient experience measures and did not see any striking differences in patient experience. Frankly, it was just incredibly high in both arms, which probably speaks to Brigham and Women's being a phenomenal hospital, but then also speaks to the ability of a home hospital setup to deliver very high patient experience care. So really wanted to start to wrap up and hope to get a lot of your comments with kind of the second part of the presentation. The Boston Globe did a fun piece following one of our patients around in 2016. Please feel free to look that up if you want a patient's eye to what happened. And we also were recently on the CBS National Evening News. Also, again, followed one of our patients during her acute hospitalization, just to give you some more insight into the program and to see some more visuals. So where are we going next right now? A lot of really fantastic places to go when it comes to new technology, and we're always looking for new partners and new ways of doing things. And so we have some in-home sensing right now, but we're always looking for new options to be able to appropriately and comfortably follow our patients while they're acutely ill. in order to better predict deterioration as well as improvement in wellness. And then lots of robotic companions and assistants are on the table right now. For those of you who aren't familiar, that lovely looking little sea otter is in almost every nursing home in Japan. It's in several randomized controlled trials. It's been shown to reduce depression among nursing home patients in Japan. It's a very effective tool. And then this robotic companion is part of an EU study that is trying to improve medication adherence in the home, as well as activity among older adults. And then don't laugh, we are working on drones for home hospital because really to improve our logistics and to improve our scale, we're going to need quick, easy ways of delivering some of these things. And so we're looking at what the easiest way to do that is right now. And then starting to look at next generation analytics and alarms. We are only grazing the surface right now in terms of how to analyze some of the data that's coming into us, particularly, for example, from the patch. So our patch data can produce a three-dimensional accelerometry plot with an X, Y, and Z axis drawn all over the place. And frankly, no one taught me in medical school how to read a 3D accelerometer plot of a patient. And so I can ask for steps to be gleaned from that, but really, I think we're only touching the top of what we can, or in our infancy in understanding that. And so hoping to be able to work in this area in a much more intensive way to really glean more predictive ability about someone's deterioration or their improvement from our data that we have. And then really working to improve our field laboratory diagnostic array and to almost replicate the firepower that the ED brings with it in terms of quick diagnostic ability, whether that's imaging, whether that's microbiology, whether those are biomarkers, and learning how to improve a lot of the abilities that we have in the home right now. So how do you think about buy-in for this? Because I get asked this a lot from multiple centers around the country, and it's a great question because this often seems like a win-win-win for patient, provider, and payer. And so it really is all about finding the right context and the right setup. And so I think there's a few cases that can be made. First is the financial case. So for health systems that are in a shared risk or even capitated setup, this makes all the sense in the world almost immediately. And that's because you can provide a high quality, safe, improved patient experience care setup at a lower cost for acutely ill patients. And so if you are on the dole for all of a patient's care, this makes a lot of sense. For fee-for-service systems, the way that home hospital immediately makes sense is for hospitals that are far over capacity. And those certainly exist around the country. Most major academic and medical centers, for example, are over capacity in their general medical ward. And this immediately is allowing you to build more hospital without bricks and mortar, essentially. And so it really offers a unique opportunity for those hospital systems. To be honest with you, the payment structures are changing, and I'm happy to talk about that in the Q&A if it's of interest. But those are really the areas right now where home hospital can and should immediately be a program that's delivered. I think the patient case is an interesting one, and it's really highlights this interesting idea of that we do a great job of funneling patients into certain types of care. So we've taught people that if there's an urgent need, they should go to urgent care. If there's an emergent need, they should go to an emergency room and get admitted. And if it's just no big deal, they should try to wait and call their doctor later. We know, obviously, that many people mistriage themselves. But we also know that Americans perceive the hospital, the traditional hospital, as the safest and best way to get intense or acute care. And I really want to try to start to challenge that perception in America because we do a lot of harm in our hospitals. Most Americans probably don't remember those stats about that we kill over 2 jumbo jets worth of Americans every day in our hospitals with medical errors. And so I think starting to work on a local but then regional and national level on the patient case and teaching patients that there are other sites of care other than the hospital where you should think about getting your acute care. And the same way that Americans are now going online and talking to a doctor online for their urinary tract infection, Americans are going, I believe, to start thinking about getting their care at home when they're acutely ill because of all of the benefits. And then there's the clinician case. So this has not been a struggle for us at Brigham to find clinicians who are interested in this kind of care. It's actually an incredibly rewarding and refreshing experience for people to do this work, as opposed to what can sometimes be a grind in the hospital. And we have found that most clinicians are very, very open to also having their patients cared for in this sort of a setting and really do welcome it most of the time. It is an open question as to who is the best clinician for this role. I'm happy to talk about that more in the Q&A as well. But for the most part, we see, and we've done some studying of this so far, we see lower burnout rates in our clinicians who are doing home hospital compared to others. So just kind of wanted to close it down and look forward to a lively discussion with people in terms of the take-home idea here that reimagining the best place to care for acutely ill adults holds really enormous potential, I believe, and combining a set of digital health technology with really innovative as well as agile teams in the home, I think will prove to be a very agile restructuring of our healthcare system and one for the better. So with that, thank everybody for signing on. Look forward to a lively discussion, and also happy to take any follow-ups by email. Please feel free to reach out. Like I mentioned, we're always looking for new partners who either want to expand and open a home hospital program, but also want to join our research efforts to do that, and also people who have solutions possibly for this line of work. Always interested in speaking with people.
Great. Well, thank you, Dr. Levine. I think the good news is, you've definitely engendered a bunch of questions amongst the audience. So I'm just gonna kind of go through a list here and hopefully get some of your thoughts around these. So the first question we really have is going back to your inclusion criteria and kind of how you did the randomization for the study. Couple questions there. Probably the first one is, you mentioned some criteria. Were those more clinical criteria, or were you doing DRG, CMI? How did you kind of recognize those individuals, and then did that same criteria apply to the randomization process? Yeah, so
VJ, I think, is asking this. The criteria for randomization, so these are our very abbreviated inclusion criteria, and essentially you needed to have one of these diagnoses, and it needed to be, frankly, a slam dunk diagnosis. We were not taking undifferentiated patients who maybe had this, not really sure. So we were taking someone who clearly had cellulitis, and then if they agreed to enroll, randomizing them after that. The DRGs actually, so an interesting question, because there is no DRG right now for home hospital. However, we did level all of the patients in the study, and they all leveled at a similar acute level of care, and then were coded at similar DRG levels.
Okay, great. All right, the next question, I think, was probably going back to some of your results. There was a quick question here about when you were mentioning readmission rates, what that readmission window looked like. Was that a 30, 60, 90-day window? Could you just comment on that a little bit?
Sure. So I think this is an important distinction. It's a great question. So in the home hospital world, we think of two separate measures. One is transfer back to hospital during the acute hospitalization. So for example, somebody's being admitted with a heart failure exacerbation, and 2 days into their home hospitalization, their kidney function shoots through the roof, they become very short of breath, and we have to bring them back to the hospital because we're just not able to manage them at home. That would be considered a transfer back to hospital during the acute episode. A readmission is a readmission after discharge, so from the day of discharge to 30 days after the day of discharge, if a patient ends up readmitted to the hospital in those 30 days, that's considered a readmission within 30 days.
Okay, thank you for the clarification. The next question really has to deal with the team. I know you mentioned a little bit about the team. Could you speak, I think there's a question about how much time the team was spending in the home versus working remotely. So maybe you could comment on that a little bit around the patients.
Yeah, for sure. You know, it's really, really variable what a patient ends up spending, what a clinician how much time a clinician ends up spending in a patient's home. We bring home some very, very acutely ill patients on drips, and we bring home patients who aren't as acutely ill. And so obviously, depending on the acuity of the patient, that really then governs how much time is spent with them. On average, we're spending about an hour for a visit with a patient. The other time, the staff is, again, everybody's got slightly different roles. Our nurse may be making a case management follow-up call for a patient to make sure that their appointment is scheduled before the day of discharge. Our physician may be evaluating a new patient who's in the ED. And a lot of that is all done remotely, but certainly is time consuming to make sure that we can appropriately include patients.
Okay, great. Our next question, a couple of folks have asked about how you might go about billing for a service like this.
Yeah, that's a great question. So that's really an evolution right now. So if you go to a country like France, it is a recognized benefit of the public Ministry of France, Ministry of Health in France, to pay for home hospitalization. The same thing exists in Victoria, Australia, and actually for a time in Victoria, Australia, it was a one-to-one reimbursement, home hospitalization for hospital versus traditional hospitalization. We certainly don't have that right now in this country. There is no way to just bill home hospital, but I think that's changing very quickly. So recently, several stakeholders got together and presented to the PTAC, which is the Physician Recommendation Committee to CMS, to suggest that home hospitals should be something that is reimbursed. And it actually was unanimously recommended by the PTAC that home hospital be a benefit of Medicare beneficiaries. Where that recommendation will go, we don't know yet, but it's certainly a step in the right direction. And we do know that multiple insurance companies have publicly suggested that they are very interested and willing to pay for this sort of a model. And so we're really excited by that, and we're approaching it from that respect. And so hopefully in the next 1 to 5 years, we're going to see, I think, a sea change in how we think about taking care of acutely ill patients. And I think it's not going to be very hard for that to happen if we do get a shift in our payment mechanism. That said, we're already seeing massive opportunities for this in the current atmosphere. And if you're in charge of a Medicare Advantage plan, you could do this tomorrow. That's how the Crier piece that I cited on one of the first slides there, that's done in a large Medicare Advantage plan in New Mexico. They decided that this was a high value thing to provide for their patients. And so they said, we're going to do it. And Medicare Advantage plans can do that because they have the money, PMPM. And so I think any Medicare Advantage plan can choose to deliver this kind of a service. At the same time, all of the newly formed ACOs can also think about doing this, particularly if they have capitation. It really makes all the sense in the world to provide this as a service to their beneficiaries. And so I think those are some of the ways that those services can be billed either today or in the near future.
All right, great, thank you. And maybe building off that a little bit, and some of your earlier comments, there's a question about, are you aware of programs out there that are looking to do something similar for, let's say, post-acute SNF care, moving that to a home health model, maybe similar to the acute care model?
Yeah, absolutely. There are several people who want to move in that direction. I think there's a whole separate set of challenges to doing SNF care at home, but it certainly presents a really interesting model, one that we will likely be trialing in the future. But it's people have already trialed it in several areas. Mount Sinai being one of the stars in this area that did in the past have a home SNF program. And so I think it's very possible. I think it also would be a huge transformative program for the country.
All right, great. We've had several questions, Dr. Levine, I think, around technology. I know you covered that. I think some folks have asked about maybe in particular anything around mobility solutions. So if the patient was not functional at a higher functioning status, if you used anything specific there, and if you saw any opportunities around that.
Sorry, Eric, in terms of the technology, what specifically?
Technology and equipment. Sorry, I said technology, I meant to say equipment.
Yeah. So for example, for our diagnostic work, we were able to use some technology for point of care blood tests, able to bring in portable ultrasound, portable X-ray, as well as things like the ambulatory infusion pump was very helpful for patients and really represented a major up. Things like portable, oxygen concentrators were very important. And then these kinds of technologies here, using encrypted SMS, encrypted video, cloud-based shared task lists, were also very important to our work.
And maybe just as a follow-up to that, Dr. Levine, did you see any gaps in technologies and equipment that you were able to bring into the home where where it might have been helpful to have something else available?
Yeah, so I think that's kind of this slide here is the new technology area and where we do see gaps right now, right? We do in-home sensing. It's not as good as it can be, right? We want to be able to capture lots of other things going on in the home in an even more seamless manner. And so there's definitely gaps in our ability to sense things going on in the home. And then also we're always looking for ways that we can appropriately supplement the human workforce, right? Right now we wake people up at 2 in the morning in a traditional hospital to check their vital signs, and a person does that. We don't do that in a home hospital because we have continuous monitoring with that patch device. Similarly, I think that there are lots of robotic options that we should be looking into in order to, in a very appropriate and culturally sensitive way, provide care to patients. And then, again, lots of new technologies needed in terms of next generation analytics and alarms and field diagnostics. I think the area of field diagnostics is going to be booming quickly, and it's because of some major advances in fluid analytics that's been happening in several labs around the world. And we're really excited to start to partner with some companies around that in order to be able to massively improve our diagnostic firepower that we have in the home.
Okay. And one other just technology question I think that some folks have asked. For the project, what did you use for an EHR type solution or a documentation solution?
Sure. So at Brigham, we use Epic. And Epic right now does not really understand home hospital, to be very honest. And so we're working to build a version of Epic that really syncs nicely with our use case. And so it's certainly possible, it just takes time and money. And so we used a hybrid approach where we use Epic to document a daily physician note, and then all of the other documentation needs ends up going in a homegrown spreadsheet, honestly. That is, sounds very backward and archaic, but actually was co-developed with our amazing nurses and our physicians, and fits our needs quite well. It opens in seconds, it saves when you press save, it has all of the boxes you want, and it has none of the boxes you don't want, and it's just a very simple way to document. Certainly, it leaves out things like best practice advisories, some safety checks that we recognize we want and want to leverage from an EHR. And so we are working to build a custom version of Epic for our program's use.
Great. And that's maybe tied to that. How do you see sort of reporting working for a program like this for accreditation purposes, such as, you know, hospital-acquired conditions, et cetera? How does that tracking happen under this kind of a program?
Yeah, so it's probably a very similar version as to what happens in the outpatient setting. These patients are currently classified as outpatients. They are not classified as inpatients. That too is an evolving target, I think. But the same way that the way that we report on problems in an outpatient practice, we have a similar reporting mechanism. This is also an IRB approved study, and so we are bound by the IRB to report any significant adverse events. That goes through an entire review committee. If that review committee deems it necessary, that event is sent all the way to the IRB, who can recommend changes to the protocol and things of that sort. So we really appreciate and love that oversight because it gives us a process to learn from a safety event. That said, we are a continuously learning team. We have a lot of metrics that we continuously follow to improve our logistics and our efforts. But we do have a very structured way of reporting any sort of adverse events and any sort of health issues via the IRB.
Okay, great. You know, when we were talking about technology, I think, you know, you mentioned X-rays and echocardiograms, et cetera. Were those, if you were delivering those in the home, I think there's a question about whether that was mid-levels who were delivering them, was that a physician delivering them, or kind of how did you, is that managed very similar to the hospital scenario?
Yeah, so this is where, you know, we have the opportunity of really becoming more agile with the team that takes care of a patient. In a hospital, it's a fairly regimented where there's usually an attending physician, possibly mid-level care providers, nurses, and often techs who help the nurses and the entire unit. And so we had the opportunity here to really take a step back and say, okay, what's the minimum team needed to take care of a patient? And we started that with a doctor and a nurse. And again, I know I had said during the presentation, that might not even be the right answer. That's where we started. And so we are continuously reassessing that and thinking about the best way to take care of the patient. It may be that we need to introduce paramedics practicing at a very top of their license and even beyond what is considered a traditional paramedic license, but not really a change in the scope of their work. And maybe we should be involving a community health worker in our team to better the care that we provide to patients. Lots and lots of options there that we've been going through, but it's certainly an evolution right now.
Okay, fantastic. Right, I'm just taking a look through the questions. I think one open question that we had, and I think you probably mentioned this, Dr. Levine, but if you could remind everyone, as far as the savings model goes, you know, maybe how long was your pilot program, and how did you think about the reduction, the savings?
Yeah, for sure. So what we were able to do, and I would urge, for people who are very interested in the cost analysis, I would urge you to just take a look at the detailed methods in our paper, because as most people on the line probably know, it really does matter how you compute cost. So what we did, and I don't think that this is the perfect way, because I honestly don't know that there is a perfect way to compute healthcare costs. But we tried to take the lesser of all the evils. And what we did was we partnered with Brigham, and they were very gracious in providing us with their internal cost accounting. So what we were able to do is, for those pilot patients that stayed in our traditional hospital, in our control arm, we were able to get the direct costs of their care. So we added up every bag of antibiotics, every nursing hour, et cetera, and added all those items up to get our control arm cost per patient. And then we essentially duplicated that exact process for the intervention arm. And we were able to add up every bag of antibiotics, every hour a nurse spent with a patient, and then compared those two costs. We very notably kept physician cost out of both of those arms. And we did that for two reasons. One, physician cost is not something that's included in a DRG payment, right? Professional services are always separate. And secondly, it's very, very hard to compute per patient physician cost. And that's because teams vary, and the amount of time that's spent with a certain patient is massively variable. And so, you know, at Brigham, it turns out that there is no direct physician care. There's never a one attending physician to patient care. There's always a mid-level, there's always a resident helping on that team. And so very hard to actually estimate the MD cost to take care of a patient on a per patient level in the hospital. Much easier actually in home hospital or in direct care models, because it's just simply how many patients did you see today and how much did you cost? So we actually very, very, by default, kept the physician costs out of our cost equation, and have subsequently modeled it in multiple ways and adding them back in. That was not part of this study, but suffice it to say it comes out fairly even in terms of physician costs in the hospital and physician costs out in a home hospital.
All right. Great. Well, thank you for going through that. We've gone through a majority of the questions at this point, and I know we're kind of running out on time here. So I just want to, first of all, thank Dr. Levine again for taking the time to share this program, and all of you for joining today. And just to remind you that we will send out a recording. You will receive an email with a recording of the video, as well as the slide presentation and information on the paper that Dr. Levine has highlighted today and been sharing some of the results on, which will give you many of these details, so you'll have that for your records. And again, thank you for taking the time this afternoon to join us, and we hope you can join us again in the future for future presentations.
Great. Thanks, everyone, for joining. Really, really appreciate it.